Now, in this section, we'll talk about some acute vascular disorders or syndromes you may observe clinically. So, the first one we'll dive into are thromboembolitic events. Again, this can be, an acute thrombus or a thrombus that's become an embolus. Um, these are in individuals. These thrombi are concerned for particular individuals, especially after surgery. We see higher coagulant factors and higher levels of inflammation acutely. This actually should be a 1, not a 2. What's going on here? Okay. We use a Wells criteria to kind of break down or assess or determine the patient's at a higher risk for developing clots. So, if we go through here looking at different signs, okay, so key thing to bear in mind, the Wells score should only really be used in a patient where we're concerned about a DVT, okay? If the pre-test probability is high, then we go through the Wells score, okay? We add up these different, signs. So if they have cast swelling greater than 3 centimeters per side, side to side, they have unilateral pitting edema. Again, DVTs tend to be a little bit, it's on one side versus you typically don't see it bilaterally. It's bilaterally, thinking more systemic versus localized injury. If they have tenderness along the deep venous system, and if they had surgery or major operation within the past 12 weeks, or if they were bedridden for any long period of time. Also, it's also important to consider, is there an alternative diagnosis that would be a little bit more likely? Okay, did they just roll their ankle? Okay, did they just eat a ton of sodium causing some of these differences? So again, always you factor in other things as well, and we only really use a DVT if an individual again has a high pretest probability. You don't do this on every patient. You should look out for DVTs, but you don't run every patient through a DVT through a Wells score, because it can end up giving you a false positive. Okay, if a patient does have a at least a moderate Wells score, they'll end up getting a D dimer to rule in a DVT. D dimer is released when a thrombus is formed. It's basically the body is trying to break down a clot, and we start seeing this like fibrin byproduct released into the blood. And then we see patients often get a vascular ultrasound to see if perfusion is maintained or impaired. Wells score for pulmonary embolisms are as follows. The general way we kind of go about this, so the things that kind of jump out at you should be anytime a patient has had a history of a DVT, or had a history of a PE, or had surgery, they have tachycardia, and they have hemoptysis, so they're coughing up blood. Okay, that should clue you in for them being at least moderate concern, and maybe we should probably get imaging. These are probably the most classic presentations: tachycardia, hemoptysis, and history of previous DVT or being bedridden. Okay, patients of cancer or malignancies are higher risk due to some of the inflammatory changes that happen with cancer. Okay, in these individuals, anyone with a score above 4, so even if they have moderate risk, they'll still probably get D dimer, and if it's a little bit higher, they'll probably get an imaging like a CAT scan to see kind of what's going on here, or even a PET scan to see if there's significant changes of perfusion in the lungs. Okay. Next, we'll dive into acute coronary syndrome. So a couple different variants of this, and we'll kind of dive into it here. So within our ischemic syndromes, we've got a few types. So angina pectoris, which we have stable, Van angina, unstable angina, silent ischemia, myocardial infarction. And we'll talk about the differences between those. So ischemia is a condition of imbalance between myocardial supply and demand, again, often caused by atherosclerosis of the vessels. It can also be caused by impaired diastolic relaxation, but in most instances, we're thinking impaired supply. Okay. So some causes of increased demand, we talked about exercise, cold weather could possibly due to changing vascular resistance, emotional stress can lead to increased demand, or even just any spontaneous change to heart rate and blood pressure. So if you get, someone comes in and like surprises you, that can lead to very abrupt changes in heart rate and blood pressure. So that's why they tell you sometimes like, don't scare your old Uncle Isaac. It could be a concern here. Okay. Causes of reduced supply could be impaired aortic driving pressure, impaired ventricular function, or increased coronary resistance for a number of reasons. Um, you know, the supply-demand imbalance then results in angina due to ischemia, okay? And you can end up seeing an ischemic contracture of the myocardium because if you don't return blood flow to the heart, we don't deliver ADP to break the myosin actin-myosin cross-bridging, leading to this almost like this contraction, almost like a rigor mortis of the vessel, of the myocardium. Okay, so we lose pumping performance again because we don't have the ATP to recontinue the power stroke within the sliding filaments, the myofilaments of the myocardium. And again, just breaking it down here, the things that can contribute to myocardial oxygen supply as well as myocardial oxygen demand. Okay. And when those are imbalanced, we get angina. So angina can be, again, we have three major types of it. It's defined as chest pain or discomfort caused due to cardiac ischemia. Okay, it's described by patients as a heaviness. They almost will often say, like, it feels like I have an elephant sitting on my chest. It's a tightness or a pressure-like pain. The discomfort generally gradually builds and may often subside if it's a stable type. We'll talk about the difference between those. And usually episodes only last about 15 minutes. They often get confused with digestive disturbances because quite often sometimes patients with GERD or gastric reflux can get like symptoms in their chest. However, patients often with chest pain or heart attacks can also have emesis. So you have to differentiate, diagnose those two. We have three major types: so stable, unstable, and Prince-Mental. Prince-Mental is we call it's an angina you get from vasospasm, almost like a Raynaud's phenomenon. It's not due to Raynaud's phenomenon in the coronary. It's not due to a lesion in the coronary arteries. It's due to vasospasm. It's temporary in nature. Okay. So angina, again, it's important to note that somatic pain, so if you roll your ankle, versus like visceral pain, you're going to have two presentations, going to be a little bit different. Somatic fibers, when we have pain, like it's typically very easily described, precisely located, and it's usually described as a sharp sensation, whereas in your visceral pain fibers, like from your internal organs, your heart, and your blood vessels, they enter at their receptors enter multiple levels of the spinal cord, so they map into different areas of the parietal cortex, or more than just more than somatic fibers do. So that's why the pain's often poorly described and can also sometimes be located in areas like not even remotely close to where that organ is. Okay, like chest pain often refers to your arm. Pancreatic pain may refer to your left shoulder, and so on and so forth. We think this is due to embryological somites, so where the organs were when you were born, and as you develop and you envelope and fold and expand, those nerve fibers from where they were with their organs may be at a completely different position they were than when you were an embryo. Okay, so basically, again, the key thing to bear in mind that visceral pain is going to be poorly described. It's going to be more of a discomfort, heaviness, or an aching, and it may not necessarily be in the same region as where the organ's located. Okay, whereas your somatic pains typically very easily described. Like if your back hurts, you can usually point to right where it hurts, or if your knee hurts, same idea. Whereas like if you have GI issues, it kind of feels kind of vague, and discomfort or chest pain is going to feel this kind of vague heaviness or achiness. Okay. So there's two types of primary types of angina. So we have stable and unstable angina. Stable angina, discomfort gradually builds, but it often subsides with rest. So usually we see some patients maybe more of those stable plaques, where they have significant lesion, and if we get them up to a certain level of intensity, just can't maintain perfusion, they get chest pain. But if you lower that level of intensity, you give them rest, it resolves. Okay, they will improve maybe with a little bit of nitroglycerin. They're maybe not they're not as much of a risk for developing an MI. Okay, because their symptoms resolved. Okay, whereas a patient with unstable angina, so that's someone who's either had angina previously and their threshold for symptoms or exercise has changed, or it's new onset angina, so something that's like not familiar to them. They don't haven't had these symptoms before, or if it lasts for that longer than that 15-minute window, it doesn't improve with rest. It does not respond to nitros. And again, it continues to worsen. This is often a precursor to a myocardial infarction. Now, it's important to note that some patients don't report or may not report symptoms of chest pain. It's not to say that they don't, but they don't rule out these other symptoms or disregard them just because they don't have classic chest pain. Elderly patients are more likely to present with shortness of breath or altered mental status, AMS. Anytime an older individual presents with altered mental status, you should start thinking maybe there's just something's systemically wrong going on with them. Diabetics might not be able to accurately sense or describe pain. Women is actually a fairly large concern. May report nausea, emesis, jaw pain, back pain, or even neck pain instead of just chest pain. Now, it's not to say that women don't get chest pain. They often do, but you don't want to disregard these symptoms as something trivial, especially in someone who may have risk factors. And again, being aware of these things we're finding is critical to improving some of the disparities that we see in terms of the management of acute coronary syndrome, especially in women. We have a whole campaign, hashtag Go Red for Women, which will come up in February, where we raise awareness again of heart disease issues, particularly to women, and raising awareness that women can get heart disease. You got to be able to recognize these differences in symptoms. Okay. This actually translates to even bystander CPR. People not able to recognize these symptoms women may get in terms of chest pain and heart attacks. It's also important to note that if you're on a lot of drugs or alcohol or pain medications, possibly may impair your ability to perceive discomfort. And there may be even cultural differences, and language barriers may also impair the patient's ability to relay their symptoms to you. So bear those in mind too when you're working with patients. Okay. Next, we'll kind of dive into acute coronary syndrome and myocardial infarction and the differences between those two. Okay, and what's going on after someone develops just ischemia. So myocardial infarction is cell death in the heart muscle, can cause by either prolonged or complete occlusion of the coronary artery. We have two general variants of MIs. So again, if someone develops unstable angina, could be for a few different causes. We end up seeing poor perfusion. So again, we talked about we can have ST elevation in many patients. However, you can see some patients without ST elevation developing myocardial infarctions. And again, we're finding that these are more common than we may realize. Either way, the end result is still sudden death, usually by VFib. But again, it's just because the patient doesn't have ST elevation and they have chest pain doesn't mean they're not having a heart attack. Okay, it's not a necessary finding on an ECG. If you do see significant ST elevation, that should clue you in. But just because they don't and still have chest pain, don't rule that out. Okay. When patients develop heart attacks, again, it starts from the inside out, and that's because even though our perforating branches, which come from our primary vessels, our epicardial or primary coronary arteries, we perfuse from those branches, the top areas still are able to get a little bit of perfusion from these branches, and they're going to be less compressed from some changes in tissue pressure. So when someone gets a heart attack, you're going to see it more in these subendocardium, or these deeper fibers. And as a heart attack progresses and lasts longer and longer, it spreads this zone of necrosis up into the subepicardium, or the more superficial fibers. So when we have a heart attack, it starts from the inside out. Okay, and again, this is the most vulnerable region for perfusion, because these more superficial areas can get perfusion maybe from some of their epicardial arteries. Okay, when the infarction travels through the full thickness of the muscle, we call this a full thickness myocardial infarction, or a transmural infarction. Okay, causing the entire thickness of that muscle in that area. Okay. And again, just kind of demonstrates what we see here in terms of the progression. We say really a reversible injury is anything under 20 minutes of these symptoms and of this myocardial and the pathophysiology of this myocardial infarction. Okay, you know, the longer and longer it lasts, the more cell death occurs, and the higher risk of developing the deadly arrhythmia. And not being able to be resuscitated. So again, we can have two types, really, that we're really kind of focusing in on. Our type 1 MIs, where we see ST elevations, and again, positive enzymes. So when a heart muscle or any muscle dies or gets necrotic, it releases enzymes, okay? Because the cells swell, they rupture, and they release all the enzymes contained within them. So we see a spike in troponins. You may even see spikes in creatine kinase MB, which is a cardiac-specific creatine kinase or enzyme. But we often see troponins as our go-to enzyme. However, someone could have ST depression and chest pain and all those symptoms, and they can still have positive enzymes. So that biomarkers are really what we use to determine is someone actually having a heart attack or not. So again, just because someone doesn't have ST elevation does not mean that they are not having a heart attack. Okay, the enzymes are what clues us in to the presence of cell death. Okay, so they'll hook them up to an ECG, run some enzymes, and then end up going to the cath lab to open up those vessels. Okay, now in terms of signs and symptoms, these are some signs and symptoms here that help describe whether a patient is probably having an MI. So again, is it associated with exertion or things that increase demand? Does it spread to the left arm? Is it described as pressure? Whereas if the patient is reporting their pain as sharp, probably not as likely an MI. If it's not associated with exertion, probably not an MI. One of the key things as well, is it reproducible palpation? If I can poke on your chest and reproduce your symptoms, it's probably not coming from your heart. It might be coming from your ribs, might be coming from your intercostal muscles. Again, that's kind of a hallmark sign. So typically if someone comes to my clinic and they have chest pain, the first thing I typically do is I poke on their chest and see if I can reproduce their symptoms or not. And if I can, I'm not thinking it's due to an MI. It might be other causes. If it's described as positional, if you have a chest pain, it doesn't matter if you're sitting up, if you're leaning forward, leaning back, laying down, you're still have an MI, okay? So you'll still have chest pain, okay? So it doesn't matter how you're positioned, okay? So if someone reports that, well, they have chest pain when they lay down, but when they sit up, it resolves, I'm not too concerned that they have an MI, okay? Maybe other causes, okay? Is it sharp in nature? Remember, visceral pain from organs, typically a little bit more vague in nature. Now, there are some other conditions that may cause sharp chest pain, like a PE or something like that, but we're not thinking MI. MI, again, is non-positional, unrelenting chest pressure and pain, okay? And this is an example of kind of where this chest pain distributes in patients with myocardial infarctions, okay? Sometimes patients don't get left arm pain. Sometimes they get jaw pain, sometimes they get right heart pain, sometimes they get back pain. So don't just, again, think it's just left, arm tightness. There could be other clinical manifestations as well. Okay. Here's a nice kind of graph here, or image here, which you can use to determine if a patient's having a heart attack in your clinic. Come from the Canadian Medical Association Journal. So again, older men, older women, do they have cardiovascular disease or cerebral vascular disease or even peripheral vascular disease, like PAD? Do they have, is the pain worse with exercise, okay, or with exertion? And is it not elicited with palpation? Okay, so if the patient has chest pain and I can poke on their chest and cause their pain to worsen or change, probably not an MI. If the patient assumes their pain is of cardiac origin, quite often the patients who have had heart attacks know what they feel like. Okay, so if they are feeling like they're having the symptoms, wouldn't be too surprised if they're actually having an MI. So you can add these together, and if you can see this, a likelihood ratio of 4 to 5 is, here is pretty strong. Okay, so it's something you can even use in your clinic practice. And this won't be the first time you see this model here. So clinical implications for PTs: patients should always have their nitroglycerins with them if they're doing exercise training. If they have heart disease, should always be monitoring patients for heart rate, blood pressure, rate pressure products during exercise, those with cardiovascular disease, and understand how to administer nitroglycerin if you're working in cardiac rehab. Typically, the rule goes: if a patient has symptoms, you have them stop. You issue a nitroglycerin. You wait 5 minutes. You go again. You don't want to be giving those multiple times. Some facilities say it's after the first nitroglycerin, then you contact emergency response. Some say if you take it 2 times, then you contact a medical response. But that will be facility dependent. The key thing is you really don't want to make sure you don't give a patient multiple nitros like within less than 5 minutes in between each other. This could bottom out their blood pressure, and you'll learn more about that in cardiac pharmacology. So I hope this was useful to you guys. Again, we're going to cover some of these concepts again in other lectures throughout the semester, and we'll come together as a group later on in the following week to describe and kind of discuss some of these concepts covered here. Okay, so thank you.